Good evening, everyone. Let us understand the causative etiology of abnormal uterine bleeding. And FIGO has given an acronym for understanding the causative etiology of abnormal uterine bleeding, and that is PALM COIN. With PALM, we understand that we are talking of P for polyp, A for adenomyosis, L for leiomyoma, and M for malignancy of uterus or hyperplasia. And by COIN, we understand that we are talking of non-structural causes in which C stands for coagulopathy, O stands for ovulatory dysfunction, E for endometrial causes, I for iatrogenic, that is physician-induced, and N for not as yet placed in none of the categories it is placed. So I'll be talking in brief about the palm and coin etiology, and today let me discuss about the important etiology of abnormal uterine bleeding, that is polyp. So polyp is an abnormal outgrowth either from the endometrium, from the endometrial tissue, or from the myometrium in the form of fibroid, which maybe once was an intramural fibroid which developed here, then it came back here and it became submucous fibroid, then it again protruded outside, became a sessile polyp, and finally in the due course of events it became a pedunculated polyp. Another very rare form of polyp is mucosal polyp, which mainly arises out of the mucosa, and it is seen out hanging sometimes from anterior and posterior lip of cervix or sometimes from the endocervical canal region. So now to understand polyp, first let us understand what type of abnormal uterine bleeding this polyp is causing. So polyp, since it is an outgrowth and is an extra proliferation, so first and foremost, it will cause heavy menstrual bleeding. Second important thing, which is almost pathognomonic of a uterine polyp, is having an intermenstrual bleed. And this intermenstrual bleed is random, not cyclic. It is not following any pattern. So if patient is coming to you with, say, heavy menstrual bleeding, and she says that she has intermenstrual bleeding, which occurs at any time of the cycle, then we must think that maybe we are dealing with a case of polyp of the uterus. Then third thing, it can sometimes come out of this uterus and sit here at the mouth of cervix, and it can also cause post-coital bleeding. Because now, as soon as there is coital trauma, the congested surface of the polyp is quite friable and it bleeds on touch also. So to summarize, the kind of abnormality in bleeding pattern caused by polyp is one, heavy menstrual bleeding, second, intermenstrual bleeding, which is random, and third, maybe postcoital bleeding. Sometimes because polyp is not responsive to the hormones, the normal estrogen and progesterone proliferations and cyclic durations, so it may cause sometimes persistent or prolonged menstrual bleeding even after the menstruation stops. So if such kind of complaints are being made by the patient, we should think that we are dealing with a case of polyp. So that was about presentation. Second is, what is the particular age group that polyp is presenting? So it can occur across the entirety of the reproductive age group. And if it is occurring in postmenopausal females, we must rule out any exogenous hormone intake, especially tamoxifen. So when we are sure that these two are not the things, then she should be evaluated for the possibility of a malignancy. Third thing that we should remember about polyp is, after its clinical presentation, is are these polyps, at higher risk of having or being converted into malignancy. So the literature is divided in this perspective. Some authors are saying that polyps larger than 1.5 centimeters may turn out to be malignant for a duration of, when 5 to 6 to 10 years. And some authors are saying that malignant potential of the polyps is extremely rare, and it happens only in 0.1 to 0.1% of the cases of polyps. And if this malignant transformation is happening, it starts at the base or pedicle of the polyp. So when we see a case of polyp, along with typical history and presentation, what are the modalities by which we can diagnose? So before we come to the diagnosis, let us understand, as I was talking earlier, that polyp can be sessile polyp where it is quite attached with a base to the endometrial and myometrial junction, and it can be pedunculated where it develops a peduncle, and it tries to come out of this uterine cavity, and sometimes it may be just a cervical polyp arising out of the endocervix or exocervix region. So how do we diagnose? So after the typical history is sort of, you can go for transvaginal sonography. That is quite nice modality to tell about the presence of endometrial polyp. Now, whenever we send these patients for transvaginal sonography, sometimes you may get a simple report of an endometrial polyp, but sometimes radiologists do say that the endometrium is thickened. So when endometrium is thickened after you do a urine pregnancy test, and if endometrium is thickened beyond 15 millimeter, always and always think of endometrial polyp along with endometrial hyperplasia. So now it's our duty to differentiate between endometrial hyperplasia and endometrial polyp. So the second modality that is important and by which the sensitivity and specificity of diagnosing endometrial polyp is 99% is saline infusion sonography. So this is a ultrasound in which the anterior and posterior uterine wall, and it is done transvaginally. They have been separated, you know. So whenever you are instilling this normal saline, these two walls are separated, and you can beautifully see a space occupying lesion. So this is an endometrial polyp, and as I said earlier also, specificity and sensitivity is quite high, that is 99%. So first modality to diagnose endometrial polyp is TVS, simple one. Second is saline infusion sonography. If at all there is any doubt, then we can go for MRI, which is not routinely recommended because of availability and obviously the cost factors and the value of benefit. Because saline infusion sonography, TVS, they're so good that after doing MRI just for diagnosing polyp, we are not adding much to our armamentarium. And third, if you suspect polyp in a case of postmenopausal female, then as I said, the malignancy has to be ruled out. So in that case, you can directly go for a hysteroscopic and diagnostic hysteroscopy in which you can visualize the polyp directly and take out that polyp and send it for histopathological evaluation. So I will repeat the diagnostic modalities for endometrial polyps. One is TVS, second is saline infusion sonography, third is hysteroscopy, and if needed, then an MRI. So after having diagnosed these things, how do we treat that? Because, you know, the patient is coming with heavy menstrual bleeding, prolonged menstrual bleeding, intermenstrual bleeding, postcoital bleeding. So they need to be removed. So how much should be the size of polyp for it to be removed? So size of the polyp that needs removal, again, the literature is divided over that. Some people say that less than 1 centimeter or equal to 1 centimeter polyps should not be removed. But yes, if the patient is symptomatic, then as a clinician, we would like to remove that polyp. So how do we remove that polyp? If the polyp is sitting at the mouth of cervix, you just, you know, hold it from here, twist the base using a sponge holding forceps and remove it. Some people recommend the usage of cautery for burning out the base so that it leads to less recurrence. And yes, after you remove the polyp, you send it for histopathological evaluation. Some use hysteroscopic guided polypectomy where they do cold knife excision of the polyp. Some may use energy devices so that the bases of these polyps are burnt out again so that there is least chance of recurrence. So the treatment for endometrial polyp may be medical. If the polyp is not that large, then you can prescribe styptic agents like tranexamic acids for maybe temporary relief. Second is when the problem is too symptomatic, problem is too much, or the medical treatment has failed, which they usually don't respond to, then you go for polypectomy. So polypectomy ideally should be done under the guidance, and hysteroscopic guided polypectomy is the best modality. But yes, if your setting is not having that thing, then blind procedure, like earlier we used to dilatation and to do dilatation and polypectomy, that can also be done and subjected for histopathological evaluation. Now, a word about what are the problems apart from abnormal uterine bleeding that a polyp can cause. So, a polyp can cause subfertility because, sometimes these polyps may be sitting at the cornua, blocking the cornual region. Sometimes these polyps may be so large that implantation is practically impossible. Sometimes these polyps may be coming out so that the ascent of a sperm is completely out of the question. So apart from abnormal uterine bleeding, polyps may cause subfertility also, and there they need a definite removal. Third thing is, I have mentioned it earlier also, malignant transformation. And if at all an abnormal pathology is present in endometrium, the authors of which I have searched, they recommend removal of the polyp as soon as it becomes symptomatic. And yes, with this, we will be able to remove the adjacent endometrium also, and we will be able to rule out endometrial malignancy and hyperplasia if at all it is present in the adjoining area. So polyp is a troublesome problem, and without exogenous usage of hormones, it is a problem and it needs evaluation and treatment. Treatment usually is in the form of surgery, that is polypectomy, and polypectomy can be done either as a blind procedure or hysteroscopic guided. So if you have any questions regarding AUBP, then we can discuss it in the question and answer segment. So that's all for polyp today. Thank you.